Hello, everybody, and welcome to Vaccine Safety Surveillance in Canada, Opportunities for Equity. This is a partnership with CAIRE, the Canadian Association for Immunization Research, Evaluation and Education. My name is Margaret Howarth-Brockman, and I am the Senior Program Manager at the National Collaborating Centre for Infectious Diseases, or NCCID. As a moderator, I'm joined today by Dr. Manish Sadarangani, Executive Board Chair at CAIRE. NCCID is hosted by the University of Manitoba and is situated on the ancestral lands of the Anishinaabe, Anishinaabeg, Dakota Oyate, Denisovan, and Nehethwak Innuwak nations. It is also in the homeland of the Métis Nation. We are on Treaty 1 land, and we recognize that this and other treaties have been implemented as part of a process of colonization intended to benefit some while harming others. The effects of colonization can be seen today in various ways, and they continue unmitigated sometimes. This webinar series has been I'd encourage everyone in attendance to reflect on the calls to action for the Truth and Reconciliation Commission and the calls for justice from the National Inquiry into Missing and Murdered Women as we work together towards reconciliation. NCCID is funded by the Public Health Agency of Canada as part of a 6-center program. We offer knowledge, translation, and mobilization on a variety of topics for public health use to improve practice and policy. Today's webinar is a conversation. We have 3 guests who will each tell us about their different approaches to vaccine safety surveillance in Canada, the strengths and challenges of these approaches when considering vaccine safety with an equity lens, and we've asked them to discuss opportunities and changes to make vaccine safety surveillance more equitable. We will make sure there is time for your questions and comments during this event. You can enter them at any time in the Q&A tab, and they will be moderated at the end. We hope to be able to respond to as many of your questions as possible. I am joined today by my co-moderator, as I mentioned, Dr. Manish Sadarangani. He is the chair of the CAIRE and director of the Vaccine Evaluation Centre at the BC Children's Research Institute, the Children's Hospital Research Institute. He is a pediatric infectious disease specialist and assistant professor with the UBC Department of Pediatrics. He has worked in pediatrics throughout the world, including in sub-Saharan Africa, Asia, Australia, North America, and Europe. His research links clinical trials with basic microbiology, immunology, and epidemiology to address clinically relevant problems related to immunization and vaccine preventable diseases. And you're going to introduce CAIRE to us, I think.
Yes, thanks, Margaret. Did you want to go through these slides, or do you want me to go through?
Sure, go ahead.
Them? Yeah.
So
the specific objectives before I get into CAIRE are for people to appreciate the different approaches we have to vaccine safety surveillance. I think we all know that there's a lot of information out there, and these different approaches that you'll hear about are looking at things in different ways, and it's really important that we have all of them to bring it together. We want to understand strengths and challenges of the different approaches when considering safety surveillance through an equity lens, and discuss how we can move forward to make this more equitable within the Canadian context. So the next slide, please. So yes, Margaret mentioned, I'm the chair of CAIRE, which is the Canadian Association for Immunization Research, Evaluation and Education. Many of you may already be members of CAIRE, but the real goals of CAIRE are to foster research collaboration and networking across Canada, to support evaluation of public health policy, and also education related to immunization. We have various activities. This slide is just a bit of an overview. So we have various awards and grants to support immunization research and evaluation, particularly focusing on early career researchers and trainees. We have a number of events that we provide access to for members and for non-members. There is a very nominal annual membership fee, and then all the events are free to members. We have various offers and online resources to help connect members and for networking and other professional opportunities, and the networking across people working in vaccinology across the country. So just a couple of events I want to bring your attention to. So one is the CAIRE Research Symposium happening later this month in Ottawa. So this is happening in conjunction with the Canadian Immunization Conference, and it will be on the Monday, the day before the official conference starts. And again, on the equity theme, the topic for this year's Research Symposium is equity considerations in immunization research, evaluation, and education. So really, we'll be looking at how to incorporate and measure EDI in different study designs, and working with community partners and incorporating community perspectives. There's a QR code and the link there, and then that will also be shared in the chat. And so if you're interested in hearing more, please have a look at our website. And again, here's a QR code for people who are interested in joining CAIRE. And I would strongly encourage all of you, if you're here, that means you're interested in the topic, and I'd strongly encourage all of you to join. Thanks.
Thank you. So it's now my pleasure to invite our three guests. Starting in alphabetical order, Dr. Naveed Janu is Director of the University of British Columbia's Center for Disease Control at the Faculty of Medicine and a clinical professor at the School of Population and Public Health, UBC. Also the Executive Director of Data and Analytics Services at the BC Center of Disease Control. He uses real-world big data cohorts for the study of infectious diseases, health disparities, health outcomes, safety and effectiveness of prevention and treatment interventions, and program monitoring to generate real-world evidence. Dr. Matthew Muller is an infectious diseases physician and the medical director of infection control at Unity Health, Toronto. He has been involved in the development of infection control guidelines at the provincial and national level as the former chair of the Ontario Provincial Infectious Diseases Advisory Committee on Infection Prevention and Control, and as a longstanding member of the Public Health Agency of Canada's National Advisory Committee on Infection Prevention and Control. Dr. Muller is also the co-lead of the Canadian Vaccine Safety Network. His research interests include the prevention of healthcare-associated infection, particularly via hand hygiene and vaccination, and emerging infectious diseases. And Dr. Sarah Wilson is a public health physician at PHO, Public Health Ontario, where she specializes in vaccine program surveillance and the public health management of vaccine preventable diseases. She is an associate professor at the Dalla Lana School of Public Health at the University of Toronto and is a senior adjunct scientist at ICES, formerly known as the Institute for Clinical Evaluative Sciences. She's been a member of Canada's NACI since 2020 and is the scientific liaison for Ontario's Provincial Immunization Advisory Committee. During the rollout of COVID-19 vaccines during the pandemic, she was the medical lead for passive vaccine safety surveillance in Ontario.
Thanks,
Welcome
Margaret.
to our guests.
So before we get into the sort of conversation around equity, I'm just going to invite each of our speakers to give a very brief overview of their surveillance approach, their network, and potentially using some examples of how this was used during COVID-19. And then before we start with Dr. Wilson's presentation, just to note that Dr. Karina Top, who was the other panelist that was advertised, unfortunately has had to is not able to attend this morning due to unexpected reasons. And so we've got a couple of slides around the network that Dr. Top leads that I will present when we get to that. But I'll invite Dr. Wilson to go first and tell us more about passive safety surveillance. Thanks.
All right, well, thank you very much. I'll just manage, can I just get a bit of a nod to see if you can hear me okay?
Yes.
Okay, excellent, excellent. Thank you so much. So thank you so much for inviting me to be a part of this, I think, very thought-provoking panel. Before I get going with the passive vaccine safety surveillance overview, I want to just note that today I'm presenting to you from a place we call Toronto, but for thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, the Haudenosaunee, and the Mississaugas of the Credit. And I'm very grateful to have the opportunity to work on this land. So if I can ask our colleagues to advance the slide to the next one, please, and I'll walk you through and give you a bit of a background in terms of passive vaccine safety surveillance. So passive vaccine safety surveillance, what it involves fundamentally is it receives and analyzes reports of adverse events following immunization. And I think, more generally, what is an AFI? An AFI, oftentimes we describe it as an unwanted or unexpected health event after someone has been vaccinated. So there's that relationship in time between the vaccination and the health event. But it's really important, and I do want to ensure that I emphasize that AFIs, they may be related to the vaccine, or they may have entirely occurred by chance. And I think that's a really fundamental component of AFI reporting. The AFI report is submitted without undertaking, any causality assessment. We want to receive all reports. And the final thing I want to emphasize in this slide is that passive vaccine safety surveillance is really a core component of public health's mandates, and it's a really core component of public health surveillance activities. If you can go to the next slide for me, please. So I thought what I would do is walk through, the process that is incorporated in passive vaccine safety surveillance, starting first at the point where someone is vaccinated. And I thought that this might be helpful, first of all, explaining how the data is collected and used. But I thought it would also be important as we move into the forward discussion about equity and thinking about various steps along this pathway and how they may intersect as we discuss equity further. So first of all, at the far left, you'll see, someone is vaccinated. And then sometime after that vaccination event, that person experiences a health event. And then in this particular schematic, I've indicated that they see their healthcare provider. But I'll also note that some individuals may decide to report symptoms or their experiences directly without first seeing a healthcare provider. But for most adverse events following immunization, someone does seek out medical care. They do see a healthcare provider, and then the healthcare provider makes a decision about whether they submit an adverse event following immunization report to the public health unit. And as I mentioned, there are opportunities also in most jurisdictions for clients to send those reports directly. So the form is completed, and the form then is submitted to public health. After public health receives the form, they do a number of things. They assess the information that's been provided. In many cases, this may result in going back to the reporting individual, oftentimes reporting clinician, requesting more information. They may also be providing advice to the client and or provider about subsequent vaccination. And they also have to make a decision about how that information is entered into the provincial surveillance system. So that then also occurs, that information gathering occurs, any investigation notes, and that's documented and entered into the provincial surveillance system using provincial surveillance case definitions. And then at the provincial level, that data is also reviewed. And many times, certainly in Ontario, we carry out our own provincial level analyses, as well as the process of transferring that data at the PT level, at the level of the province and territory, and sending it to colleagues at the Public Health Agency of Canada so that those AFI reports are included in the national system, the Canadian Adverse Event Following Immunization Surveillance System. And I want to be sure to really emphasize this because this involves the collection of reports from across Canada and is very important in terms of the ability to identify rare or very rare adverse events. And of course, our colleagues at the national level have an opportunity to collaborate and discuss vaccine safety with other global partners. So next, if you can move along to the next slide, I'll just briefly summarize some of the strengths and challenges or limitations of passive vaccine safety surveillance. So in terms of one of its strengths, in I'll say many or most jurisdictions in Canada, the process of healthcare providers reporting adverse events to local public health is actually mandated in provincial legislation. In Ontario, it's the Health Protection and Promotion Act. So there is a legislative mandate. It's not just a nice to have. There is actually a legislative framework for saying healthcare providers really should be reporting these events. And that also supports public health units in the framework and the permissions for them to go back to clinicians and say, these are the additional things that we need to support our investigation and learn more about this particular adverse event. I think I've previously mentioned that the reports are analyzed also at a national level, and that's very important in terms of having the strengths of numbers when we're looking at rare or very rare events. And then the final points there summarize this kind of message I keep going back to about the role and the opportunity of passive vaccine safety surveillance in terms of the opportunity to quickly identify vaccine safety signals and also detect rare and very rare adverse events. But of course, it's also known to have a number of limitations, as all surveillance systems have their strengths and limitations. So passive vaccine safety surveillance is known for something called reporting bias. So, certain events, in particular, more severe events, tend to be reported more commonly than other events. And there may also be something called stimulated reporting. So if an event is in the news, that might prompt clinicians to report. We also know there's challenges with underreporting. So despite the legislative framework I've mentioned that's in place in most jurisdictions, this is an additional request for clinicians, and we know that not all adverse events are reported. There's also variable quality in those initial reports, and I've sort of highlighted how public health goes back to clinicians to collect more information. That's obviously a very timely process, and there are oftentimes challenges with capacity in terms of following up with additional details collected on every single AFI. And then the final piece is not having an unvaccinated comparator group that's present in some other vaccine safety surveillance designs. And this is addressed in passive vaccine safety surveillance by comparing rates in passive surveillance data with what are described as background rates of events. And I suspect my colleague who will be speaking about administrative data will be discussing how administrative data can be very helpful in terms of providing those background rates. And then if you can advance to the last slide, I just wanted to briefly return to the strengths of passive surveillance in terms of the ability to rapidly respond or rapidly identify vaccine safety signals, respond and detect rare and very rare adverse events. And during the COVID-19 pandemic, we saw that passive surveillance identified very quickly the two vaccine safety signals I've noted there, TTS, or sometimes called VIT, after adenoviral vector vaccines. In Canada, that was AstraZeneca, and myocarditis and pericarditis after mRNA vaccine. So wanted to note the role of passive surveillance in first identifying those vaccine safety signals and shaping the public health response to those. All right, so I'll hand it over to the next speaker. Thanks for the opportunity to give that overview.
Thanks, Dr. Wilson. So we'll move swiftly on to Dr. Muller, who's going to tell us about active safety surveillance that he's leading with Canvas.
All right, thanks very much, Manish, and I'm glad to follow Dr. Wilson because I think she set things up very nicely. And so I'll just talk briefly about what active surveillance is and then explain what we were doing at Canvas. And so active surveillance, rather than passive surveillance, where people are reporting after they've had a health event or an AFI, as described by Dr. Wilson, active surveillance involves recruiting participants usually at the time that they're vaccinated. So at that point in time, you don't know whether they will have any type of health event or AFI or side effect from the vaccine, but you're just recruiting a group of people who you can then follow forward in time to see if they develop a health event or don't develop a health event. One advantage of active surveillance is you can also include an unvaccinated control group. So a group of people that you follow in a hopefully similar way to monitor health events in that population. And so one of the potential strengths there is the ability to distinguish between health events that might be associated with the vaccine and health events that just occur at a certain rate in the general population. So it might be concerning if you found that 12% of people vaccinated had a severe headache, but then if you found that 12% of the general population in your control group also reported a severe headache in the same time period, it would be reassuring that this is nothing to do with the fact that they were vaccinated. Active surveillance also helps with the reporting bias because we're not relying on individuals or healthcare workers to decide who to report into the surveillance network and who not to report. But each person is expected, who's participating, expected to share what happens to them through the surveillance period. And it also allows some, in some cases, better data quality. So if you're enrolled on the day that you're vaccinated, you're quite likely to remember the specific vaccine you received, for example. But if you report a side effect through a passive system several weeks later, you may be less sure about exactly exactly what happened. And we have the ability to control exactly what we're asking people, what information is being collected. So Canvas is the Canadian National Vaccine Safety Network. We've conducted active vaccine safety surveillance for a number of different new and old vaccines since 2009. And I'm going to focus on our experience with the COVID vaccine. So the safety network operates in 7 Canadian provinces and territories that account for 85% of Canada's population. And the recruitment of people into our safety surveillance varied a little bit from province to province, but at a high level, many of the larger provinces had a centralized way of tracking people receiving COVID vaccines. And by collaborating with public health and government authorities, we were able to enroll people through that system with the consent of participants, allowing us to access very large numbers of potential participants across Canada. And Canvas ultimately recruited almost 1 million Canadians to participate in the safety surveillance. So once people, essentially you would be vaccinated, and through the registry, you would receive an email asking you if you're interested in participating. And if you consent to participate, the data was collected through a series of surveys that you would receive after you receive at certain time points after you were vaccinated. I think it's important to set up our discussion later of equity to talk about who could participate in this surveillance and who could not participate. And as I said, we recruited large numbers of people and had very broad inclusion criteria. You simply had to reside in a participating province. But the main issue was you did have to be able to answer a survey in either of Canada's official languages of English and French. And you had to provide a working email and a working telephone number for our follow-up. And I meant to mention earlier that those that reported quite severe health events that would require hospitalization, for example, were followed up by telephone to collect further information. So essentially, we took a large group of people, mostly vaccinated, but also a group of unvaccinated people, and then we checked in with them at different time points to see if anything had happened. And we're able to monitor for different health events in that way and compare the rate of those events between people that were vaccinated and those that were unvaccinated. So I will stop there.
Thanks, Dr. Muller. So we'll move on to Dr. Janjua, who, as Dr. Wilson mentioned, is going to talk a little bit about using health administrative data.
Thank you very much for inviting me to talk about vaccine safety monitoring using linked administrative data sets. Next slide, please. I would like to start with the acknowledgement that this work was carried out and I'm joining from the traditional, ancestral, and unceded territories of Coast Salish people, Musqueam, Squamish, and Tsleil-Waututh nations, and I'm greatly privileged to be living and working on this land. Next. When we seek care from a healthcare system, data is generated, and these data are captured in various healthcare data sets. And when we integrate various data sets together, it allows us to create a longitudinal medical history of individuals who have sought care, and which could be used for evaluation of intervention effectiveness, for example, vaccine effectiveness, and also could be used for monitoring vaccine safety for certain events. And integrated data sets have been used for vaccine safety for some time, but historically in Canada, these data sets were not that timely to allow real-time surveillance. That changed during COVID-19. Next slide, please, which allowed us to create platforms similar to BC COVID-19 cohort across Canada. And I will describe here the platform that we have in BC, which integrates provincial healthcare administrative data sets with provincial registries, demographics, laboratory, and COVID-19 data sets on all BC residents. So that means like it captures entire population and has a very large sample size. These data sets are refreshed on daily or to weekly or monthly basis, depending on the data set. And a historical data present in these data sets allows us to create medical history to allow us to identify individuals with certain medical conditions who may be at higher risk of certain adverse events or also lower vaccine effectiveness. As part of this work, we also did some validation studies to validate certain events against medical charts to assess the validity of these measures. Next slide, please. So I will take myocarditis as an example to walk us through how we use this platform for assessing vaccine safety. As Dr. Wilson described, initial signals related to myocarditis were identified through passive surveillance, and following these signals, multiple studies were conducted to investigate these signals. Within BC, we also conducted multiple studies, and then we collaborated across with investigators across Canada for multi-provincial study as well. So some of these studies were looking at observed versus expected rates of myocarditis, where we are comparing number of events which were observed and compare that to the background rates, which provides us a kind of notion of unvaccinated population and rates within that unvaccinated population. And then we also conducted comparison of myocarditis and pericarditis between two vaccine products, mRNA vaccine with one or the other vaccine. Next slide, please. So this slide shows some of the results from observed versus expected myocarditis rate, and we saw that the rates were higher among young adults. Next slide, please. When we stratified these data by age, sex, and vaccine product, we were able to pinpoint that most of these events were among males ages 18 to 29 years who received Moderna vaccine at that time. Next slide, please. And when we did comparative study comparing Moderna and Pfizer products, we were able to further confirm that the rate of myocarditis and pericarditis was higher among those who received Moderna among people ages 18 to 39 years, and of course, like among males as well. Next slide, please. Just to summarize, this healthcare integrated data platform could be used for detection of safety signals as well as evaluation studies to confirm some of these signals. And one of the major strengths of this platform is large sample size. For example, here we're talking about all individuals who received vaccine within BC, and then when we did a comparison of data across a few provinces, we were able to accumulate sample size of about 18 million people, and we assessed myocarditis following vaccination as well as infection in these 18 million population, and that provides us opportunity to assess safety signals and confirmation for rare safety events. But one of the problem with administrative data sets is that it is prone to misclassification bias. Sometimes these events are not very specific, and the specificity could be enhanced by use of clinical data and laboratory data, which is becoming available in many provinces. And again, like we could use standardized protocols across jurisdictions, which could help compare safety events, and it could also increase the sample size for investigating rare events. Next slide, please. Next slide, please. So I would like to acknowledge our partners who helped us to create this data platform, and thank you very much for your attention.
Thanks, Dr. Janjua, and just a final disclaimer. So as I mentioned earlier, unfortunately, Dr. Top is not able to join us today. I have a couple of slides that I'm just going to briefly run through on her behalf to talk about the Special Immunization Clinic Network, which she leads. This is one of the networks as part of the Canadian Immunization Research Network. So Canvas that you heard about earlier is another network from CERN. And this is really, you've heard about 3 approaches that are looking at, population based on numbers of millions, and this is looking at a much smaller, more targeted population. So this network operates across Canada. I'm the lead investigator for the network in Vancouver. And the aim is to standardize and improve immunization practices for patients with previous adverse events following immunization. So we have a national team of expert clinicians with an interest in vaccine safety, which encompass infectious disease specialists, allergists, immunologists, and some other specialists. And essentially, we see patients who have been referred to us by another provider. So that can either be through the public health system, through a medical health officer, through a pediatrician for the pediatric patients, to an adult provider or whoever other clinicians. So they get referred to the clinic, and this clinic, so we're seeing these, very specific group of patients that provides a platform for research. And this research is very much integrated with clinical care. So as I mentioned, the provider refers the patient to the special immunization clinic locally. We have a very standardized assessment of the adverse event. So some of this will be similar to what's reported through the passive system, but some of it is very specific, and we're able to look at specific high-risk groups, for example, children. We've done studies, for example, in children with leukemia, in children who have been exposed to immunosuppressive medications during the pregnancy of their mother. And then we assess them, we collect the data, and then we make a risk-benefit assessment to whether or not they should proceed with revaccination. I would say the vast majority of times of the patients we see, we do recommend revaccination based on evidence-based protocols that we use in the network. And then the vaccinations, we provide them in our clinics, or they can be given through public health or their community vaccine provider. And we also then collect the data of what happened after their revaccination. And so did they have a repeat of their AFI? Was it the same? Was it, what was the severity, etc.? And so we're able to really collect a lot of data on a relatively small group of individuals for this follow-up. And then all of the data is entered into a single database that is analyzed. And to our knowledge, this is sort of the largest network of its kind anywhere in the world. There are other similar networks, but really the data have been used to inform a lot of vaccine policy in Canada and internationally. And I think that's the last. Yeah, so the key points really is that we have a standard approach that really is trying to support revaccination of patients with AFIs. We're able, because we have that infrastructure, to pivot. And so during COVID, we developed a number of protocols to specifically investigate the signals that were coming out of these other networks to look at specific issues in COVID. And where our current gaps in access include adults and people in rural and remote regions. And unfortunately, Dr. Top isn't here to speak more to that, but the network has definitely historically been focused on children. During the COVID pandemic, it did expand to be more inclusive of adults, but that's only been able to be supported at some sites. And also, while a lot of the clinics do offer virtual health as well as in-person appointments, I would say there still tends to be a bias towards individuals who live in more urban areas. I think that is the last one of Dr. Top's slides and his acknowledgements of the rest of the network. So I'll stop there.
Take that one down
hand it
for
back
now.
to Margaret.
Yeah. Thank you. Thank you all for setting the context for this webinar. Before we go into the specifics of discussing equity in vaccine safety surveillance, we'd like to just take a step back and ask if you can comment briefly on approaches for evaluating equity in terms of vaccine uptake, which would of course inform your data sets. So Dr. Wilson, I'll start with you.
Great, thanks very much for this question. And I really appreciate this question because I think we really can't look at vaccine equity or equity and vaccine safety in isolation. I think we really have to look at it across our different vaccine surveillance systems. So I think the key issue here is really around the state of our immunization registries across Canada. I think all of us know that there's in many cases a lot of progress still needing to be made on that front. But I think it is also helpful to think about some of the really positive developments that occurred during the COVID-19 pandemic. At least in my province where I practice in Ontario, we had the implementation of a COVID-19 vaccine registry that had almost real-time data. And that real-time data supported area-level measures of understanding patterns in uptake, so looking at different characteristics of different communities. And there was also some very important work in relation to the collection of individual-level sociodemographic information that was done in partnership with a number of communities, specific groups, and requiring a fair bit of training among immunizers. And so I think those are two really promising developments arising from the COVID-19 pandemic that will be really important to think about how those can be incorporated into the work of building, strengthening immunization registries more generally in the time ahead.
Thank you. And now I'll ask the same question of Dr. Chenjua.
Thank you. So within linked administrative data sets, data flow from vaccine registries and get linked with the administrative data sets. As Dr. Wilson explained, with COVID, we had these additional data sets available, and we were able to target and expand vaccination based on the areas where there were gaps. But some of the additional benefits that could come from these linked administrative data sets, we could assess disparities in vaccine uptake by variables which may not be available through vaccine registries, such as socioeconomic status, ethnicity, rurality is available, and certain other indications or measures that are not available in the immunization registry. But again, there are certain indicators which are not available in linked administrative data sets. And that comes back to the entire discussion related to how we are measuring equity, and do we have indicators for measurement of equity in our health system data sets. And that is a very important aspect for us to consider going forward.
Thank you for that. And Dr. Muller, in the work that you are involved in, how is equity already considered in terms of vaccine uptake?
Yeah, I don't know if I have too much to add to what the other speakers have said, except for just reflecting on that question really made me realize that you can't talk about equity in the surveillance part unless you have equity in the administration part. So obviously, Canvas recruited a very large number of Canadians, but most of those were vaccinated Canadians, and we could, if you're not vaccinated, you can't be tracked as a vaccinated individual to monitor safety. And so then when we're feeding this information back and looking at subsets or specific groups within our total data set, we may have some groups that are underrepresented. So I think the two go hand in hand and are extremely important. But other than that, I don't have much to add.
Thanks. So I think accepting that, that is essentially a caveat of the discussion that is to come. If you're not vaccinated, clearly you can't be included in any safety surveillance. Let's move on to talk a little bit more about vaccine safety and the challenges specifically related to equity in the approach to surveillance that you've already described very, very clearly. So which are the populations that we may not be representing? So Dr. Muller, you sort of briefly mentioned the limitations in terms of sort of some of the technological accesses that people need for Canvas, but maybe give you the opportunity to go first and expand on that.
Yeah, and we've been focusing as an example on COVID vaccines, but important to remember that there's safety surveillance that's necessary for many vaccines. And one thing that Canvas is attempting to do for the first time this year is look at the safety of the RSV vaccine. And in Ontario, this vaccine has specific indications, one of which is that elderly individuals in long-term care setting. And when we tried to apply our model to that population, it's very challenging in terms of the ability of them to receive and respond to emailed surveys, and it may not be something that works effectively in that setting. And so that may be a group of people that we inadvertently excluded from our COVID surveillance. We had lots of older Canadians included, but probably not that many from nursing homes and retirement homes. So that's just one example. Obviously, socioeconomic status may play a role there in terms of, again, access to email or having a working phone that we can reliably contact people through. And so we may have a somewhat biased population and reduced equity for that reason.
Thanks. Yeah, so Dr. Wilson, in terms of the passive surveillance that you've described, where do you think those gaps may be? What populations do you think maybe underrepresented potentially?
Yeah, I think it's a really thought-provoking question, and it's, it's part of the reason why I sort of mapped out that different sort of the timelines of activities, because I think when you sort of look at it that way, you can see how, for example, groups or populations or individuals who don't have trust in the healthcare system could be underrepresented. So recognizing that not all, but I would say the overwhelming majority of our AP reports do come from healthcare providers. So, if people aren't seeking care, that can be a barrier. I think also trust in the public health system as well. So even if a healthcare provider assesses a client, they're about to submit a healthcare, or pardon me, they're about to submit an AP form to public health. I mean, that act of reporting to public health triggers a number of subsequent steps, requesting additional information, et cetera. So some clients might not be, might not provide their consent to the healthcare provider to enter into that process. Again, I think going back to the themes of trust and confidence. And then I'd say one of the unknowns in this particular area, it's not specific to equity. I think it's a more general comment about comprehensive data from our passive vaccine safety surveillance system, is really understanding at the provider level, what are the provider characteristics that contribute to reporting, because again, that's a key input into our surveillance system. And so I think it's easy to imagine and think out loud about how there could also be a relationship between healthcare provider characteristics and the communities they serve, and how that can sort of intersect and influence reporting. Thanks.
Thanks. Yeah, and Dr. Janjo, same to you. Obviously, you're looking at the data that exists in a different way. So where do you think, for the administrative data analyses, that some of these concerns may be?
So just building on some of the comments, there are certain measures that are not available in healthcare administrative data sets, and it comes down to collection and recording of these, whether it's even if you look at a collection of data related to gender, so that is not part of our health system data. So that highlights like how basic needs are, even starting from that point of view, to start measuring and collecting data on equity-related measures, so that we could incorporate these into vaccine coverage surveillance, but also into the vaccine safety surveillance. And then some of the populations where access to care, or there are barriers to care, they may not come forward with the adverse events, because healthcare administrative data sets are based on seeking care. And if people are not seeking care, they have other competing priorities. And that is true among people who are unstably housed or people who choose substances. They have a lot of other competing priorities. And that is where some of these data sets are lacking in providing good picture into what is happening in these populations.
Thank you. For our next question, I was going to ask what each of you would answer in terms of what would you need, dream big, and how could you address the gaps that you've already commented on. And this is sort of exemplified by the question that we already have in the Q&A, which is, what are your opinions on the best ways to reduce systemic barriers for rural, remote, or other underserved populations? Katie King has talked about Indigenous relations, newcomers, 2SLGBTQA+, persons with mental health challenges, unhoused, which we talked about a little bit. So how can we unpack those challenges and the barriers that you've talked about moving forward? Dr. Muller, would you like to go first?
Sure. So, again, I'll answer at least to start with, specific to Canvas. So I think there's some low-hanging fruit. As I mentioned, our survey is only in French and English. And so that's an easy fix to look at other languages commonly used in Canada that would increase access to a variety of groups doing things that way. I also look back in time, and when Canvas started, there were some paper-based approaches used, at least for recruitment. And although we don't have the resources to recruit 1 million people with pen and paper and clipboards, reflecting on this, whether we could work with stakeholders in key underserviced areas and try to connect in a different way. It was very efficient to connect through a provincial vaccine registry, but potentially that could be supplemented, for example, by interacting with the Indigenous healthcare organizations to reach out to them and maybe have information come out through their email to their group, to their population that might be more trusted and more supported. So I think we could enrich our group by engaging more with stakeholders as we're collecting the data and trying to recruit more diversely across Canada. Also reflecting on how we share the information on the other end. So I didn't mention in my presentation, but we were regularly tracking for health events and generating reports that were shared with public health. But again, if we want to recruit more people from different groups, it would be nice to share some of the safety data, first of all, directly with them and not through intermediaries, but also reflecting their own population. So to do a subgroup analysis, for example, and say, what does safety look like for your population, and share some of that data. So I think those are things that could strengthen our approach going forward.
Thank you. I think those are some examples of tried and true opportunities that could be followed up on. Dr. Wilson?
Thanks for this question. And I think, to me, the way I think about this is it goes back to how do we improve vaccine confidence in general. And I think we also know, and this is one thing that I think we haven't yet really discussed in a lot of detail, about how fundamental vaccine safety and people's perceptions about whether it's done, how that information is shared, how that actually really impacts people's perceptions of vaccine safety and their ultimate trust and confidence in vaccines. So, I think we need to think about communicating about vaccine safety, how it's done, acknowledging the self-awareness that it can always be improved. But we need to really talk more about how vaccine safety is so critical, what we're doing, and how to collaborate with partners in the community to ultimately improve it when we're talking about our efforts to work alongside community partners to really build trust and improve vaccine uptake overall. So I think we really need to look at these different components together as a system. And I think the way this question is framed, I think it also speaks to, perhaps for us in public health, communicating with communities about how they can report adverse events without relying only on healthcare provider reporting.
Thank you for that. And Dr. Genju, anything to add from your perspective?
So I would just build on that and say that the community engagement and participation of community is really key to enhancing vaccine confidence, but then also coverage as well as safety. And empowering communities to design outreach activities for vaccine, and then engaging them into looking at the data, both from the coverage as well as safety point of view, could really enhance vaccine uptake as well as safety surveillance. And another aspect for us, which I highlighted previously, is measurement-related issues in the health system. And at the federal level, we need to have measurement of various equity-related indicators so that we are able to report out data where the gaps are in collaboration with communities, so that their thought process is included into the reporting, and then we address where the gaps are.
Thank you.
Thanks. So we've got a few minutes here for some audience Q&A, and there's a few questions already that have come during the course of the session. And if anyone has any other questions, we'll get to them. We've got about 10 minutes here. So I think maybe building on some of this discussion we've just been having, I'll pick up on one. I'll not necessarily do them in order, but trying to keep the conversation flowing. Pick up on a question from Noni McDonald. I don't know who wants to take this question, so I'll put it out there and then you can decide who you want. So she's just made a comment that in Australia, there's a GP vaccine surveillance network, and could a similar model be developed for vaccine surveillance for the elderly in long-term care, rural, remote, school-based New Canadians, etc.? Who wants to go first?
I mean, maybe I could weigh in briefly just because I brought up the issue of long-term care, and I think that makes a lot of sense. And I think there's not, we talked today about 3 different ways of doing safety surveillance, but there's many ways, and there's no one way that can solve everything for everyone. So, I think for some of those rural and remote areas, or for long-term care, a network like that may make a lot of sense and may complement other types of surveillance.
Any of the other panelists want to add to that?
Maybe I'll just add to me. To me, the suggestion or the sort of thinking about a provider network arrangement for augmenting surveillance, to me, it really raises the question of, what are the ways that we can improve healthcare provider reporting by making it easier? I've no doubt that this surveillance network doesn't require printing out paper forms and faxing it and determining where to send the report to. So I think there's also insights that we can take away from that sort of strategy in terms of thinking about, like, just in general, how do we improve reporting by making it easier? And I think I mentioned earlier, we ask clinicians to do a lot of things, and this I think oftentimes feels like a bit of a could potentially feel like a task or a burden. So how do we make this easier? What are the IT tools? How do we really support this? And I think there's likely insights that we can gain from those sorts of approaches, just to apply it to our passive surveillance more generally.
Yeah. Dr. Ginger, anything you don't feel you have to add anything. If you have anything to add, though, please feel free.
I would say technology is really key, especially with respect to reducing the burden at primary care providers. Otherwise, it won't happen.
Yeah. So maybe, Dr. Ginger, while you've got the mic, so there's a question here from Monica Nass that analysis of administrative data is generally considered to be hypothesis generating or potential signal detection. And her question is, what is the state of our infrastructure to conduct hypothesis testing studies in Canada?
Yeah, I think administrative data sets could be used for that purpose. And again, I think like some of the key issues have been a lack of specificity, but it varies by outcome which we are looking at. And validation of outcomes, bringing in laboratory data for confirmation, or imaging data or other clinical data for confirmation, could help us to build that infrastructure. And during COVID and post-COVID, there has been a lot of movement, and that is where like we need to go to strengthen that infrastructure, and that will enhance our capacity to do hypothesis testing using administrative data sets as well, because that is where like you have very large sample size and power, and you could take these signals and then test them, comparing vaccinated or unvaccinated and comparative product type studies as well.
Thanks. Yeah, Dr. Muller, go ahead. I see you unmuted.
Yeah, I just was going to add that Canvas already has some of this capacity, really largely based on the fact that we have both a control group and a vaccinated group. So we're able to test for associations or differences in rates of events between those groups. We also have a built-in mechanism to test a new hypothesis. So the surveys that go out to individuals ask about a number of possible health events. But if there's a particular concern about an unexpected health event, we can add a trigger and follow up people with that event through phone calls and other means. And so there is some adaptability to that system, that if there was a new hypothesis that a vaccine was associated with something, I'll say hair loss, because it popped into my head for some reason, we could add those questions to the survey relatively easily. We could phone people that say that they had that effect to get more information as to whether it seemed like it was related to the vaccine or not. And we could compare that with the reporting from the control group. So there is some capacity within Canvas to draw associations and test hypotheses.
Thanks. Dr. Wilson, anything you want to add to that specifically?
I think it's been well covered.
Okay, that's fine. So there's 3 questions here that are really more or less focus on passive surveillance. So I think a couple of them, hopefully we can just get very, very quick answers, Dr. Wilson. So the first question from Noni McDonald is, do you think we'll get annual or biannual CAIFIS reports again, with the last one in 2019? So I don't know if you mentioned CAIFIS, so do you know?
Well, first let me respond to say I think that this is really a question for our colleagues at the Public Health Agency of Canada, so I don't really feel well positioned to answer it, although I will say that I think our colleagues at the Public Health Agency of Canada did a really outstanding job in terms of public transparency of COVID-19 passive vaccine safety surveillance data. So passive AP reports that was updated on a very regular basis on a public-facing website. So I do really want to acknowledge that, because I know that's always a theme here in terms of public transparency, in terms of the sharing of this, both with the communities, the public, providers, et cetera.
Sure. And then another one, again, maybe just if you could answer very briefly, because there's a longer question that I do want to get to. So did you notice in your system reporting of AVs relating to COVID vaccines during the pandemic? How does that compare to sort of before and since the pandemic? Have you noticed a difference?
Sure, I'll try to answer this succinctly to say that in the early periods of the COVID-19 vaccine rollout, our reporting rates for all APHIs, so all categories of APHIs combined, were quite considerably higher than our standard AP reporting rates. And to me, I wanted to really emphasize the challenges with communication around that, because I think it's easy to look at that and say, oh my goodness, there's a problem, these vaccines aren't safe, as opposed to clinicians, our community partners, we're working together as a system, we're getting great reporting, this is a good thing, and this is how we can really be confident about vaccine safety surveillance. Because I can tell you that's not the immediate conclusion that people draw when they see AP reporting rates being substantially higher. So to me, the theme there is really around some of the challenges of public communication in regards to this information, what it means and what it might not mean. And I think that's a very nuanced thing that can be quite challenging.
And I know we're almost at time, but there is one more question, and I do think it's an important one. So again, it's more around the passive surveillance. So maybe Dr. Wilson, I'll put here from Robin Harrison. So so you mentioned that most of that surveillance is really done by healthcare workers. So do you think we could better engage and support frontline healthcare workers to improve systematic reporting for the passive system, and to improve equity in advertising, the opportunity to participate in active surveillance? I guess that's more for Canvas. So, and she's given some examples of regular reminders of the legal requirements where it is in legislation, or easier reporting electronically, or just sharing the reports with them more systematically. So yeah, I know there's a lot there, but yeah, maybe you have some thoughts on that, or things that you've tried.
Yeah, so thanks, Dr. Harrison, for that really, I think, insightful question. There's a lot to unpack there, but I guess I would say that we certainly, and again, I'll be providing my response from an Ontario perspective. I think that anytime there is a new vaccine, and we know in recent times there's been many new vaccine programs introduced, that there's always a reminder to clinicians about the legislative framework for reporting, how to report, tools for reporting. But the point is well taken about the importance of ongoing reminders. But I think it's also really important, and I mentioned this earlier in some of my comments about how to make this easier for clinicians. I think that's really important. And during the COVID-19 pandemic in Ontario, there was some movement in this area in terms of some collaboration with again, it was a particular EMR vendor, but trying to incorporate AFI reporting into the EMR workflow. And so I think that sort of strategy has a lot of promise. But again, we need to think about that across the system in terms of how to make reporting easier.
Thanks. I don't know, Dr. Jandua, Dr. Muller, any final thoughts on that in the last sort of 30 seconds here before Margaret wraps up?
No, thank you.
Well, that hour has gone very quickly. I really want to thank our three guests for all your insights, which you conveyed so succinctly to us, and to our participants for joining us. A real special thanks to our colleagues at CAIRE, Paneet Gill, who's on here, and Dr. Sandangari. Thank you very much. I'd also like to thank Zeeshan Cutter from NCCID for his support for these webinars. Thank you again. Please take a moment to complete the short evaluation, which will pop up on your screen when you leave, or you can get it from the QR code that you can see right now. A link to the recording and perhaps the slides, we'll check with our guests, will be available to anybody who registered through Zoom and also on our website at nccid.ca and CAIRE's website too, I believe. So thank you again, and have a lovely afternoon.